Hi, everybody, and welcome to our module on geriatrics. A geriatric syndrome is a name geriatricians use to refer to a group of very common health problems among the elderly that are usually multifactorial and they don't fit into a single organ-based category. So, for example, many elderly patients, like this man shown on the screen here, have issues with cognitive impairment, weakness or fatigue, and frequent falls. None of these things are usually due to a single problem like a single muscle issue or heart issue. They're usually related to multiple different organ systems, all sort of having issues in concert together as the person gets older. When geriatricians evaluate an elderly patient, they conduct what's known as a comprehensive geriatric assessment. And in doing this, they assess the patient for all the items I've listed on the screen here. Each of these is something that is often a problem for elderly patients, and if it's identified early, potentially there's an intervention that can help prevent problems down the road. So in the rest of this video, what we're going to do is go through each of these items. They often come up on step 1. It's usually just 1 or 2 questions, and if you just know the vocabulary, it's usually easy points. The main way that we assess functional status among the elderly is to determine whether that person can do what's known as activities of daily living. And in day-to-day practice, when people talk about activities of daily living, they are talking about the basic activities of daily living. These are basic self-care tasks like bathing and walking, and we'll talk about what they are on the next slide. But basically, patients who are unable to do these basic ADLs need a very high level of assistance in their life. Usually, they need to live in a skilled nursing facility or what other people call a nursing home. Now, besides the basic ADLs, which are what most people mean when they're talking about ADLs, there are a couple of other types of ADLs that geriatricians sometimes discuss. Instrumental activities of daily living, or IADLs, are tasks that are required to remain independent. These are things like cooking for yourself and shopping for groceries. Patients who are unable to do these can often live independently, but they need some help. They may need someone to cook for them or go to the grocery store for them, but they're able to live in their own apartment and bathe themselves and dress themselves and do basic activities. And then finally, the highest level of ADLs are the advanced ADLs. These are things like participating in family, social, or work-related roles. Elderly patients who are able to do these things can really function in society just like a non-elderly person. Listed on this slide are the basic ADLs. When you hear people talk around the hospital about whether or not patients can do ADLs, this is usually what they are referring to. The basic ADLs include things like feeding, bathing, dressing, toileting, transferring, which means getting up and out of a chair or up and out of bed, and walking. And like I said before, patients who are unable to do these things usually require a very high level of care. On this slide, I've listed IADLs. These are things like shopping for groceries, driving or using transportation, using the phone, working around the house or repairing things, preparing food, doing your laundry, taking medicines, managing finances. Elderly patients who are unable to do these things can often live by themselves, but they need some help, either from family or there are many places called assisted living places where elderly patients can have an apartment, but someone comes every day to help them with the things listed on this slide. Let's talk about falls. Falls are very common among the elderly. Half of patients over 80 fall each year, and questions about falls are very common on the STEP exams and even the internal medicine and emergency medicine exams. There are many risk factors for falls. The most important one is prior falls, so people who have fallen once are likely to fall again. Other risk factors include weakness, balance problems, and arthritis. And then a very high-yield risk factor to know about is certain drugs that affect the central nervous system. So hypnotics, which are drugs like zolpidem, zaloplan, or azapaclone, these are sometimes given to help people sleep, and they are associated with a higher rate of falls among the elderly. Also, benzodiazepines, drugs like alprazolam and clonazepam, these are also associated with falls among the elderly. So in a board question, an elderly patient taking one of these drugs who's having falls, the right answer may be to stop that medication. We generally try not to prescribe these to elderly patients because of the risk of falls. You may be asked on your exam how to prevent falls, and the best prevention is exercise. This is usually the right answer, and most people aren't aware of this. There is very strong evidence that elderly patients who do strength training, like this man in the picture, or gait and balance training, or even Tai Chi has a lot of evidence around it. These types of things tend to improve muscle tone, and they're strongly associated with less falls. Other things associated with less falls include avoiding certain medications like we talked about on the last slide. A home safety evaluation is usually performed by a visiting nurse who goes out to the home of an elderly patient, and this is done to try and prevent falls. So this person will make sure that there are handrails on the stairs, that there are rails in the bathroom, that the lighting is good, and that the bath mats won't slip. And when this is done, this often limits falls by taking away things that might cause falls and making sure there are rails that patients can grab onto. And finally, I'll mention walkers or canes. Many elderly patients need these for mobility, but you should be aware that there really isn't much evidence that they prevent falls. In fact, there is some evidence that they may cause falls because people think they're capable of more than they are because of the walker or cane, and they try to do too much and then they fall. So in a board question asking for how to prevent falls, a lot of people will choose the answer a walker or a cane, and that's usually the wrong answer. In elderly patients, we screen for cognition and mood. So cognition we screen for because the incidence of dementia increases with age. And also, this is often undiagnosed. Many elderly patients can hide their cognition problems by trying to always talk about familiar things. But if you screen them for this and ask them for detailed answers to questions, you'll uncover the fact that they are having memory problems. Same is true of mood. Depression is very common in the elderly, and it's often undiagnosed. And elderly patients that are depressed often don't function very well. They don't exercise, they don't get out of the house, and they're more likely to be hospitalized. So screening for depression among the elderly is something that's commonly done. Let's talk about polypharmacy. Elderly patients are often on multiple medications, and they usually have multiple providers prescribing these drugs, maybe a primary care physician, maybe several specialists. So for this reason, reviewing the meds is one of the most important things that is done among elderly patients. In my own practice, most of my patients over 80 years old take 10 to 15 daily medications. So reviewing this list to identify interactions or unnecessary drugs is very important to prevent med errors and also to limit patients from taking drugs that they don't need. Screening for problems with social or financial support is important among elderly patients. Strong social support has been associated with better outcomes. So elderly patients who have family nearby that visit regularly, those patients do better than patients that live alone and are very isolated. In addition, many elderly patients are eligible for public financial support. So an elderly patient who doesn't have many resources and doesn't have transportation, you can often plug them in with public financing to help them stay on their feet. And then finally, caregivers of the elderly often develop depression and burnout. And when this happens, the elderly person gets sicker because they've lost their caregiver. So screening for these problems is a way to identify them early and try to intervene before something happens. You should be familiar with the term goals of care. For many elderly patients, full health and independence is not possible. Patients just can't go back to being the same that they were when they were 18 years old. So goals of care is the process of determining together with your patient what is most important. Maybe the most important thing is living at home and not going to a nursing home. Maybe the most important thing is meeting with friends or attending family gatherings or walking without a walker. If you can figure out these things, you can focus the care on those items. For example, I have elderly patients who are limited by heart failure, but I had one patient in particular whose most important item was playing bridge every week, so we worked with her family to get her a ride so she could play bridge. So even though I couldn't reverse her heart failure and make her young again, I was able to plug her in with the activities that are most important to her. And when her spirits are better and her mood are better, she's less likely to get sick and end up in the hospital. So goals of care involves determining what is most important, also what is less important, what are things that the patient doesn't value. And patients vary in what they value, so when you figure this out, the care can be guided to that specific patient's desires. And then the last thing I'll mention that's important among geriatric patients is advanced care preferences. These are their preferences if their health deteriorates, especially if they cannot make decisions. And I talk in detail about advanced care planning in the video on decision making, where I talk about what to do if patients can't make their own decisions. And that concludes our video on geriatrics.